Good afternoon, dear ladies and gentlemen.
On advances in telemedicine, connected health, connected wireless health, and the data and big data that is changing the way that health is being organized around the world, and especially in Russia and in those countries that are seeing the marriage of connected and wireless health and technologies that can improve research and also data analytics and analysis of health. Меня зовут Ralph.
My name Ralph Simon.
Session today, and we will start off the session by introducing our various speakers. Each speaker will just introduce themselves and talk about where they are from and why they are here and some of the work that they do. And then we will go around the round table for some presentations of some slides by certain of the speakers, and then we will have a debate, and we would like to also have all of you maybe ask some questions, and we will have an interesting discussion about touching the edge of the future and being healthy because we're touching it. So first of all, I'd like to introduce you first. Just the sound just needs a little bit more treble and a little more less volume. I want to introduce our first guest from Austria. Has traveled all the way from Austria to Moscow. Gunther Schreier is the senior scientist and thematic coordinator of assistive healthcare information technology, safety and security at the Austrian Department and the Institute of Austrian Technology. Just to give you some background, Dr. Schreier specialized early in his career in electrical engineering and biomedical informatics from Graz in Austria, the University of Graz, University of Technology, and then went on to do his master's degree at the Danube University in Krems in Austria. And he's currently the senior scientist and thematic coordinator of predictive health information systems with the Austrian Institute of Technology. He is a prolific author that has written over 300 different publications and scientific publications and presentations. He teaches at 3 universities, 3, not 1, but 3. And you can see that he's very, very hip. If you see in his one ear, is that electronic bioinformatics in your ear, or is it just an earring?
Yeah, that's an accelerometer that counts my steps.
Very good. Dr. Schreier's expertise are, in fact, biomedical informatics, the interoperability of ICT infrastructures, biomedial research, mHealth, and predictive modeling. He is currently the Secretary General of the Austrian Society of Biomedical Engineering and has served since 2007 as the founder and president of the annual scientific conference in Austria, Health Informatics Meets eHealth in Vienna. Dr. Schreier.
Ladies and gentlemen, dear colleagues, dear Mr. Chairman, thanks for this introduction. May I have my slides, please?
Can we have the slides?
Well, until I get the slides, I would like to tell you, you were mentioning keeping in touch with health, and what I'm going to show you is how we understand this keep in touch and how we provide patients with ways to keep in touch with their health carers. Yeah, here it is. All I need to now is the controlling device, and then we are ready to start. I would like to introduce you to a new healthcare paradigm. It's called 4P health. I did not invent this. Actually, it has been invented by other people, and Leroy Hood nicely published about that. The 4P, actually, he was stating that the attributes that a future healthcare system should have can be broken down to 4 key terms, and since all those terms start with P, you could also say P terms. And this is, first of all, participatory. So it's about giving patients a way to actively participate in their healthcare. Then personalized, to adjust therapy to the very needs of the individual, not one size fits it all. Predictive, we need to come up with models that allow us to perceive changes in the healthcare status early, to have a chance to intervene early and to prevent problems with health, even before they occur. So that's the concept of 4P health. And I will be happy to tell you a little bit about what we at AIT our humble contributions to this concept. AIT is the Austrian Institute of Technology, and we are concerned with the infrastructure of the future. And of course, one important infrastructure is the health infrastructure. So when we started many years ago, actually, we started to build such a basic telehealth system where patients and physicians are put into a permanent communication loop. We call it closed loop healthcare. And with all those technologies available today, this is not rocket science, of course, but it allows us to provide healthcare anywhere and anytime. And then we were looking on how could we use the mobile devices, mobile phones, to provide patients with patient terminals to enter data and to communicate with their doctors in a way that allows anyone to do that, also elderly people and people that are not very skilled with technical devices, and also to include anything. So anything that is important in terms of collecting the health data at the home of the patient or on the move that is needed for the doctors to optimize the therapy of those patients. Basically, we are talking about chronic diseases, chronically ill patients, where optimizing of the therapy is important. So we came up with a solution that is based on RFID, NFC, near-field communication technology. Before I go to lengths telling you that, I will just show it to you. And that's what I meant with what you meant about touching your health. So the system is, the basic principle is quite simple. What patients have is a patient identity card. It's in my purse. I don't even have to take it out. So I just have to unlock my phone. So what I do now is just touch my identity card, and now the app comes up, and then I touch any medical device, sensor device that holds the information which is needed by the doctors to optimize the therapy, the glucose meter, or in my case, and I was lying before to you about my earring, it's not the pedometer, it's not the accelerometer, this is the accelerometer actually, but it's NFC based, and so I can just touch it and suck out the values, and I see that today I had so far some 5,000 steps. And I'm done. And the patients touch their glucose meters, their blood pressure device, their weight scales, and other items. You can use the RFID tag technology to tag any item that you like. You could, for example, put it on a medication box and indicate you took the medication just by touching the box. So it's quite intuitive. And elderly people can also use it. And it allows us to include anything to this kind of data acquisition. And in one of our large-scale pilots in diabetes patients, we are now able to look into the data situation of a couple of 100 patients. Here you can see we did an analysis on what is the impact of different data collecting technologies on the percentage of patients that stay in such a telehealth system. And as you can see from both curves, the blue curve on top shows this near-field communication-based data collecting concept, and the red curve is the conventional web-based method. And you can see that patients using this mHealth NFC-based methods stay to a higher degree, significantly higher degree in the system. So it really helps to include anyone into such systems. By the way, we call it keep in touch because it keeps you in touch with your doctors and you just touch the things that are important to your health. Now, okay, so far we've succeeded and now have a way of collecting all those data in the telehealth setting at home and on the move from the patients. And the question is, where will the disruptive, creative disruption come from in healthcare in the future? And I think, of course, we need to make progress in a lot of different areas, but it's very important that now we start to integrate all those data that we have from a variety of sources. This brings us to the big data analytics kind of approach. And you can see here the telehealth, we managed to get the telehealth data, but we have also to look at the other data, so the demographic data, the electronic health record data. We are still very poor in squeezing out the information that we have in the healthcare records, biomarker, of course, but then also we need to tap into lifestyle data. We need to understand what people, how their lifestyle is, and also social data. It's very important to understand, for example, that the social situation of a patient has changed because this poses this patient in a position that he or she may be develop a further worsening of the disease or depression or something like that. It's not about just physiological data. It's about social data as well, and also environmental data. And I put a question mark to the last box because actually the real solution or problem may come from a field that we're not even now thinking about today. So there is still open questions. And only if we tap into all those information sources, we will be able to fuse those information and to model the healthcare status of the patient, predictive modeling, do a prediction how will the health status of this patient evolve, and then to prevention if we see this goes into a wrong direction. So that's the point. So at the end, let me just point out, if you are interested in this field, and you were mentioning, it was a kind to mention it, that I started, I was a co-founder of a conference in Austria that takes place every year, and this next year it will take place again in Vienna in June. It's called the eHealth Summit Austria. We do it with HIMSS Europe together, and next year our motto will be Gesundheit neu denken, which is German, personalized health, and that I think fits to the theme that I was presenting today. Thank you.
Gunther, I just want to ask you, when you speak about looking at social media, environmental information, obviously health records, is this now starting to become the common practice in Austria?
No, it's not. It did not start to become common practice.
So this area that you're in is really looking at trying to shape the future from new ways of evaluating the analytics that you can draw from, not just medical analytics, but other aspects of data that might be held by both the government and by the individual and by social media.
Yes, I give you an example. Now that we have hundreds of patients out there that do their daily blood pressure recording, we can do a correlation of this blood pressure readings with the weather data that we have on a geographic association. And we did a study on that, and what it turned out is that we have a very sharp temperature drop. Then also the blood pressure drops very sharply. So that's important to interpret health data. You not only have to look at the pure diagrams, you have to know, well, the context of that was this and that. And so that's why I think it's very important to eventually also include this kind of data. And then it's called the Internet of Things, you know. We try to put it all together, all these smart objects out there, and there's the concept of going from the Internet of Things to the Internet of Anything. This is the very new buzzword, where people are not just looking into aggregating smart objects, but also smart services of all kinds and tap into the health record and so on. So this is the Internet of Anything.
So this device that you showed here is an Austrian device?
know that this is a Japanese device, actually. It's an industry partner where we have a collaboration with, so it's NFC enabled, but the industry is all the time now building new devices that are NFC enabled. There's also some de facto standard out there, so we will see a lot of devices in the future that we can use to integrate into such systems.
So let's go to, let's fly into Moscow, and let's go to Kirill Kayem, who is the Executive Director of the Biomedical Technologies Cluster at Skolkovo Foundation. Kirill, just please give us a brief outline of what your main focus is, looking on what you feel is coming in the next 12 months.
In Russian? I mean, English or Russian? I can speak English, that's no problem. So I would say that 12 months for the biomedical project is a very short period. So if I would like to share my foresights and my vision of the future, maybe it's a bit longer period. But first I would like to talk what is Skolkovo. Skolkovo is a state foundation. The most of Russian colleagues know that we are supporting different startup projects on the border, on the edge of science and the practical usage and the business models. And for the moment, Biomed Cluster combines 220 biomedical projects, but the most of the projects are either medical devices or drug development and drug discovery. I would say that among the medical devices, some of them have some relationship with Telemed, because that's point-of-care devices. But nevertheless, if I evaluate the number of projects connected with the bioinformatics and telemedicine, that would be about 10%. Which is a big paradox for Russia, because in Russia we have very good IT technology engineers and very good engineering school overall. That means the most of this knowledge and the scientific projects are utilized in different areas, and the target for Skolkovo is to increase the number of projects in telemed and bioinformatics. Nevertheless, those projects who are dealing with Skolkovo startups, they more or less repeat the landscape of the industry in telemedicine all over the world. So in fact, there are two big areas where telemedicine concentrated. One is telehome, and the second is telehospitals. As soon as I'm talking the bunch of the projects, so I can split it. And I would say that the telemedicine exists for a rather long period. I mean, all of us who has the relationship with medicine remember such simple such simple devices like distant electrical cardiography devices was known more than 20 years ago, more than 25 years ago. Following the development of the infrastructure, computation abilities of the new computers and telecom, definitely the technology side of ITC is much more advanced than we can use it in the medicine for the moment. So basically the medicine is running behind and trying to catch the gap between the abilities and possibilities we have from the development of ICT technologies. And Skolkovo is doing, we are trying to find a project which can close those gaps within the Skolkovo Foundation. I would say that we are mostly concentrated on hospital projects and telehospital. The most of those connected, as Günther already described, with big data projects, because we are not think that's only the prediction possibility. It's not only diagnosis, but as well the big data. It can be the source of the clinical decisions and clinical tactics for the doctors. An example, we have the joint project with EMC2 Corporation with big data, which combines all omics data we can get on the market and clinical data we can gather. So we are moving this direction, in fact. Concerning telehome devices, we have few projects connected with point-of-care diagnostics with different new chips developed. So it's definitely those part which helps doctors and patients as well. If I also mentioned the Russian landscape, we have the most of the project in telemed for the moment are developed by the healthcare networks of the corporate healthcare services, such as our partner Russian Railroads. They have a big chain of the hospitals, but nevertheless, to cover all the country with the small cities and the small stations, they're making a lot of project with telemedicine, including healthcare control for the railroad operators on the spot. On top of this, I think my colleague Alexander will share it with me. There is some troubles in Russia with the law which defines the usage of telemedicine. So it's moving slow, but we believe as soon as our startup's ready, I hope in 12 months, but most probably it's a bit longer because it has to be validated clinically. We will have the law in place and we can use the project we develop.
Kirill, just explain, maybe give us 2 examples of a particular initiative you're working on now that you're seeing some progress that you can speak about, that and the particular, let's say, 2 key initiatives or projects that you're presently engaged with, that just to give a flavor of some of the immediate things you're working on.
Okay. We have, as an example, point-of-care device developed in the cooperation with German institute, Modalium with German institute, and the idea is that with this device we can use antigen antibody reaction and develop the chip which allows us point-of-care diagnosis for many up to 54, 57 on the same chip, and the size of the device is like a matchbox. And that's usually use chromatography for this one and immunography for this one. But what our startup did, they mark antigen with the marker which possible to read with electric signal. So basically that's how they come to the device size of the matchbox. And that's point-of-care device. Sorry, it's not 12 months. On this stage, it would be available maybe in 2 years. But in fact, that would allow any patient or, any housewife use this device for the short diagnostics at home to download this, the result of this lab test, in fact, home lab test, to the cloud, and any doctor would see it. We also have a few projects with IT, which are cloud solutions for the doctors. I already mentioned this big data project with EMC, so it's moving.
We'll come back to this issue of the Russian law and the difficulty about health data, because that's something that is the province of Nick Scholes that we'll get to in just a moment. But before we do, we'd like to introduce Dr. Chris Wasden, who has come all the way from a fantastically interesting city in the United States, from Salt Lake City, Utah. Anybody ever been to Salt Lake City in Utah? Very interesting, beautiful place. Chris has got some interesting paradoxes about connected health and medicine. And so we'd like to introduce the first time here at Open Innovations, Dr. Chris Wasden.
Thank you. Can you get my slide deck up, please? All right, well, they're pulling it up. Let me, oh, there we go. So let me just share with you a few bits of history here. In 1926, the front cover of Radio News magazine had a picture of a doctor doing telemedicine with a TV. The idea of telemedicine goes back almost 100 years. In the 1960s, when the astronauts were going to the moon, they did telemedicine on the astronauts there. In 2000, the VA began a lot of telemedicine that they were doing with the veterans in the United States. The challenge here is that we've been talking about telemedicine now for almost 100 years, and we still have not gone beyond pilots. Gunter talked about pilots of a couple hundred people pilots here. In the United States, we suffer from a disease, and the disease is called pilotitis, which is the disease by doing too many pilots. And so as we look at the evidence of digital health, which broadly encompasses telemedicine, telehealth, telecare, all those others, the question is, why can't we go beyond pilots? And what I've done is I've identified 10 paradoxes which are really at the root cause of the reason that we can't go beyond pilots. Let me, let's see. There we go. Okay. So my basic premise is that when we look at the cost, the efficiency, the safety, the outcomes of digital health solutions, what we find is that if we were able to package all that we do with digital health into the form of a drug that a doctor could write a script for and give to a patient, it would be a blockbuster drugs treating millions of patients, generating billions of dollars. So what's the problem? Why can't we have digital health be as successful as a drug? Part of the problem is that we have not been able to address a lot of the challenges with digital health to make it as simple as a drug. And so our premise is that if digital health is ever going to become scaled and go beyond pilots, it's got to become as simple to administer to a patient as writing the name of a drug on a piece of paper, giving it to the patient, and having them go off and have the prescription fulfilled. So this takes us to our different paradoxes. Some of these paradoxes will be particularly US focused. The money paradox is one of those, which is very much US focused, but I've seen it in the UK, I've seen it in Finland, I've seen it in France, I've seen it in Spain as well, which is that we want digital health to decrease the cost of healthcare. Yet doctors say, I'm not going to do digital health unless you pay me more. So we have this paradox where doctors want to be paid more for using digital health, but yet digital health is to decrease healthcare costs. And so when you go to many countries, you find that the doctors are unwilling to do something they're not paid to do, which is at really the core problem, because then the healthcare system sees themselves paying more to do digital health than to do it without it. The next paradox is the engagement paradox. What we find is that consumers and patients are much more engaged with digital health than they are with regular health, and that's because in healthcare there is no feedback loop. If you go visit your doctor once a year, once every 6 months, even if you visit your doctor once a month, you don't have a relationship with your doctor in a feedback loop. A feedback loop needs to be instantaneous. It needs to be in the moment when you're doing something that needs to be corrected. The value of healthcare in the digital form is that we can create, through these mobile devices, instantaneous feedback loops to create greater patient engagement. We have the adoption paradox, and here what we see is that the people that are the most likely to use digital health initially are the people that don't need it. We've done surveys globally, and what we find is that the people that adopt the pedometers, the Fitbits, all these different devices, tend to be healthy people, not sick people. So why is it that the healthiest people are willing to adopt technology that's really made for the sick people? It's because healthy people are more engaged in their health. They're more focused on health. And so the challenge is, how do we create technologies that get adopted by the sick people and just not the healthy people? The technology paradox is associated with the fact that clinicians generally are very slow adopters of technology. They tend to get stuck in a rut of how they perform medicine, and they've never really viewed themselves as technology innovators. Innovation comes from medical device companies, it comes from drug companies, it doesn't come from doctors. There can be the occasional doctor like Gunter who's an innovator, but most doctors in clinical practice are not innovators. They apply the innovations of other people. And so we can't expect doctors to take all of these different technologies, bundle them together, and come up with some innovative solution for their patient. We need to make it as simple as writing a script in a drugstore. We have the satisfaction paradox. All studies that have been done on patient satisfaction that have been monitored through remote monitoring, through different sorts of telemedicine, tell us that patients prefer digital health to regular healthcare. The satisfaction surveys are in the 85–90%. So if patients are more satisfied with digital health solutions, then why don't we provide them to them? It's because it's a different workflow for the clinician, and the clinician doesn't really feel comfortable with this different type of workflow. The next one is the feedback paradox, and I mentioned this earlier, that is that healthcare doesn't really have a feedback loop. Yet digital health provides an instantaneous feedback loop. When you take what Gunter showed you and you use all those devices, now your software in your smartphone knows whether or not you've done what you're supposed to do, knows whether or not your values are good or bad, and can give you immediate feedback that tells you what you should do differently in order to change your health care and improve it. The utilization paradox, the Veterans Administration of the United States has done extensive studies using digital health, and what they find is that utilization of the healthcare system decreases by 20 to 40% when you use digital health technologies. That is, patients don't need to go to the hospital as often if they use digital health technologies because of the feedback loop and these other things I mentioned. The paradox here is that despite the fact that utilization goes down, we really haven't seen the adoption of the technology because the healthcare systems in developed countries don't know how to save money from lower utilization. I was in Spain talking to some doctors in the government about this, and they said, you know what? If we decrease our utilization, it doesn't save us money because we don't fire nurses, we don't fire doctors, and we don't close down hospitals. So if you create a technology that decreases hospital utilization by 40%, I don't know how to save that money. The validation paradox, despite the plethora of pilots and other studies we've done, we still lack a systematic way to know which apps are good, which devices are good, which digital technologies are really the best to be used. And so we need to create a validation paradigm that is different than the drug paradigm. With the drug industry, we'll spend $100 million to validate a drug works. In medical devices, we'll spend $30 million to validate that a device works. We can't afford to spend $100 million or $30 million to determine whether or not an app on your phone works, or whether or not a $50 device that you have in your pocket works. We have to come up with a different validation methodology and approach that is appropriate for the cost and the risk associated with the devices. And the behavior change paradox. The reality is that no physician, almost no physician, has ever been trained in behavior change. They don't take behavioral psychology, behavioral economics courses. They don't understand the behavior change process for patients. They don't focus on how do I use this technology now to change your behavior on a daily basis even when I'm not there. And so we need to get into a mode where physicians understand how to use technology to change behavior to create these new feedback loops that will then deliver better outcome.
Wow, that's some really sparkling insights. Chris, obviously you come from an American perspective where the medical system and the whole notion of the way that medical costs are incurred is very particularly American. With these paradoxes, have you observed in your studies where these paradoxes apply internationally as much as they might apply in a specific American system?
For example, in the UK system, which is a system that you have employed doctors, they're not fee-for-service, they're on a fixed salary. I've met with the NHS and I've met with the Vodafone, and I managed a meeting between the two of them to talk about how to apply innovation in the NHS around digital health.
So the NHS is the National Health System, which is essentially free to citizens of the United Kingdom and Northern Ireland.
Right.
And Vodafone is the second largest telco in the UK.
Right.
So tell us what happened with that example.
So I said to the NHS, I said, if Vodafone were to deliver a digital health solution that would decrease patient admissions and decrease patient readmissions, and if they were willing to guarantee it, that is, they would pay for the solution and you only paid them based upon success, would you accept that solution here in the UK? And they said, no, we would not. And I said, why? Vodafone takes all the risk, they front all the money, you only pay them if patients are healthy and remain out of the hospital. They said, because we would be paying twice. We would be paying Vodafone for keeping people out of the hospitals, and we would be paying doctors and nurses for staffing hospitals that are empty. And so that doesn't work for us. So we have this problem that we can't figure out how to really adjust our healthcare system to realize the benefits of these technologies. The criticism in the UK of the Whole System Demonstrator and 3 Million Lives project, which was a digital health solution to demonstrate that we could make patients healthier through digital health and decrease hospital admissions, showed high patient satisfaction, showed higher patient health, showed lower hospital admissions. The criticism was they couldn't show how to save money.
Interesting, peculiar problem in the UK. Very interesting to hear that, which is maybe a good segue for Nick. Just with a lot of the work that you're doing, looking at the whole notion of one's traveling health records, so to speak. At Hitachi, just give us a view of some of the work you are currently engaged on at Hitachi. And also, if you can add anything to what Dr. Wasden has said in relation to the international view of some of these changes that are being imposed upon a medical system and upon telemedicine.
Okay, thank you very much. My slides are there as well. So just as an introduction to that, I think, I agree with a lot of what Chris said. And next time I go to my doctor, I'm going to tell him that I'm fit because I am wearing my Fitbit. So that's good that I heard it from Chris that I'm a fit person because I'm wearing one. The NHS is where I come from, the UK, and it's an interesting case. And absolutely right. We had meetings with the health ministry only a few months ago. And they are saying that the funding for hospitals has to change in the UK because at the moment they're funded by the number of patients that come through the door. We have to move to a new model whereby we're keeping patients out of hospital. We're, going back to Gunther's point, we're monitoring them, we're more proactive with the medicine, more proactive with their condition. You know, some hospitals in the UK, for example, are penalised for readmission, and that isn't common. So if you go into a hospital for a condition, for an operation or something, and you then get discharged 5 days later, the hospital then gets funding for that operation. But if something went wrong with that operation and the patient comes back in a week later, then you get funded again. That can't be right. You should do the job right the first time. You should also monitor the patient when they're at home because that's when they're at most risk. So again, it comes back to the predictive and the monitoring the patients. But you're absolutely right, Chris. The hospitals are seeing this as saying, well, hang on, if we don't do this, we don't get funding. If we don't have patients coming in, where does our funding come from? But even EU commissioners now, and there's a lot of studies and commission, and we're involved in some of the studies happening right now with e-health and telehealth and other industries in other areas, whereby they're saying that the way that we do healthcare is unsustainable. You know, we all know that people are living longer, they're more active, but then there's things like diabetes, there's things like obesity that are affecting us dramatically. So you can't keep funding healthcare as it is today. It's unsustainable. So major changes have to happen.
So from a UK perspective,
Поэтому с точки зрения Великобритании, как вы считаете, сейчас люди здоровее, чем 50 лет назад? И это сделано...
It's obesity and type 2 diabetes, which we'll speak to Dr. Avshalomov in a minute. Are we seeing, as a broad kind of population group, that there's generally better health because of better guidance and social media on keeping healthy, or are these major paradigm shifts as well that tied into some of the things that Chris spoke about a short while ago?
Okay, to answer that, I think I've got it on a slide, but I'll talk about it right now. We're involved in a large case at the moment in Manchester, in the north of England. And that is mainly, there's a number of pilots, proof of concept happening there, but one of them is around diabetes. If I tell you that the NHS UK budget per year is about 100 billion pounds.
100 billion pounds is about
budget.
6 trillion rubles.
Okay. Around 8% of that is on diabetes care in some way. So that's a huge figure. So if one of the big projects we're involved in is preventative diabetes care. So it's again coming back to the monitoring of patients who are at risk of type 1 or type 2 diabetes and preventing them getting worse, looking at their lifestyles, looking at their diet. Because again, coming back to funding, you know, out of that 8 or 9 billion pound a year that's spent on diabetes, save 10% of that. The NHS is looking to save 20% of their budget per year, year on year, for the next 10 years. So, you know, they've got to find savings somewhere. And that's just one case. So it's
Nick, let's go through some of your slides.
Okay, just very quick. I'll spend just 5 minutes just to maybe explain, who I am and why I'm here. And it's good that a number of colleagues have already spoken to some of the issues. So just a quick introduction. Probably a lot of people do know about Hitachi. We are a company of about 1,000 different subsidiary companies, making everything from nuclear power stations, bullet trains, TVs, systems, modality devices within healthcare, and I'm part of Hitachi Data Systems, which is in our information technology division, which makes up around 18% of the company. So we are the technology part of the whole group, if you like. When I was talking about telemedicine, I thought, well, what does it mean? Because it's a bit like big data, a bit like lots of other terms, cloud. It means different things to different people, e-health. So what does it mean? It means, providing clinical healthcare at a distance. Pretty obvious. Eliminate distance barriers, which clearly, certainly in countries like Russia, is very important. Improve access to medical services, ultimately to save lives. So that's a pretty easy definitions. But what we have to do is say, well, okay, where do we start with this? Well, let's have a look at, first of all, where are these medical systems? Where are these clinical systems? And if we look at, if we look too insular, but if you look within the hospital itself, what happens to the information? The information about a patient as they travel through that.
Wait, let's start even earlier. From birth, the registration of the new baby in a maternity hospital, that's the start of the registration process.
Yep. And in fact, some places I know certainly in the UK and other countries, they're actually a patient has a patient ID before they're born. The embryo is given a patient ID. So we're storing data about people even before they've been born. The information is all over the place. I think Gunther mentioned it. It's at different sources. It's in different formats. It's coming from different places. Add to the complexity is there's all different ways of accessing it. So clinicians are using viewing tape systems. We have e-health and telehealth within the hospital itself because doctors are moving around. And things like the wearable devices that we've already been mentioning. Because patient information isn't, often people look at patient information as being the data that's within the hospital. It isn't. It's much more important. But looking outside of it, where the patient is, again, coming back to my point about stopping the patient coming in the first place. And if we look at what technology is doing, just look at imaging as a simple example. The amount of data we're storing on people is dramatically increasing. We hear this all over the place in all industries, but you look at how it's happening within healthcare, and we need this information anywhere we are, which is what mHealth and telehealth is all about. But the challenge is this data is getting bigger and bigger all the time. We're storing more and more of this data. And the challenge is a lot of this data is what we call unstructured. It's not easy tables within a database. It's completely open format. It's imaging, it's video, it's audio, it's handwritten notes, etc. And that become about 70 to 80% of data within a hospital is unstructured. So that's a real challenge. And that's where the biggest growth is happening. And often when we look at what the hospital is doing, clearly it's there to save lives, but more and more now, hospitals are looking at how are we doing? How do we get our funding? Infection rates, how are we handling particular operations? How do we compare with the national average? What are our readmission rates? Because that, again, affects our funding and affects our patient.
Incredibly complicated.
It is, yeah, because it's, this data is all over the place, and what we do a lot is to, next slide, please. Thank you. Oops. Go back one. When we look at where that data is, it's all over the place. The person at the bottom left of that slide is one of our customers in Holland. He has a vault of 9 million glass slides going back 70 years. Now, clearly, you're not going to get that in any telehealth type system. But this information is all over the place, including in the cloud. So where do we start? Where do we draw the lines, if we have to, of all this information? And one of the things we do within Hitachi, if I just get the next slide. That's it. Thank you. We talk a lot about social innovation, and this goes across all industries, but let's talk about healthcare particularly, because more and more this data is machine-based, machine-generated data. It's estimated that within about 5 years, 45 to 50% of data that's created is actually created by machines talking to each other. Gunther mentioned RFID, for example, is a perfect example. These, mobile devices, video surveillance, movement detectors, this is all data, machines talking to machines. Again, this is all should be all part of our bucket, if you like, of hospital information and patient information. And again, I think going back to Gunther's point, it's not around just loads and loads of content and loads of volume, it's what do we do with it? How do we get value out of that data? And because the data's coming from different sources, that's a massive challenge as well. So a number of the projects we're working on, and this is one that touches upon some of the things we've talked about already, is centralizing this healthcare and social care information. And this is similar to a model within the NHS as well, but it is relevant to all countries in that you have funding coming from somewhere, from government or from commissioning bodies. You have referrals and data coming from GPs, hospitals, clinics, etc., and pharmacies. But more, it's the information we're getting from the patient. That's where the real difference is in the telehealth and NemHealth. It's not about purely managing the data within the hospital and the information. It's around changing lifestyles and then supporting that and advising the patients through better knowledge, through better access to that information. And then, let's extend that into things like fitness clubs and supermarkets, because a lot of hospital systems now are looking to link in to Fitbit-type devices. That's part of my hospital record, the data that's there. So it should be stored centrally, and I should have my clinician, my GP, should have access to the data I've created myself as well. In the same way as if I'm taking my blood sugar levels, as if I'm a diabetes, for example. I mentioned that. Okay. Oops. So, some of the technologies that are around already, what we're looking for is more of a patient-centric view of a patient. And what do I mean by that? Going back to the earlier points, this data is spread out everywhere. It's in paper format, it's in digital format, it's in all sorts of formats, and it's stored everywhere. What clinicians need is a single view of that patient. I don't want to have to look in 50 different places for one patient. I want to look in one place. And the technology is around to do that, and there's technology around that allows us to do that through mobile and telehealth devices. If we look at digital pathology, and digital pathology is quite a new area for a number of countries, about 10 years ago, it would take about 20 hours to 25 hours to digitize a glass slide. Now we do it in 2 minutes. Okay? So that has a huge effect on what we can then access. And bearing in mind there's a worldwide shortage of pathologists, and a lot of them are getting old, and a lot of them don't like technology. They're still based on glass slides. We can, the technology is around similar to Google Earth, where it allows us to zoom in on particular parts of cultures and samples. Again, it's all around getting feed and getting access to this information quicker. And lastly, and again it was mentioned a couple of times, is the whole analytics side of things. Hospitals and clinicians need simpler access to patients. So I want to look at a particular patient, particular age, who has this condition, using this drug. Show me the people that hit that criteria. Drill down, allow me to drill down on that information. So, lastly, just to maybe introduce some discussion points for later on. I can have the last slide. Telehealth is all about the challenge of making data more easily accessible. It's around patient-centric, so we find information easier and we find it addressed to that particular patient. We create value out of the data. We don't just store loads and loads of data and hope it's still there. We have to create value from that. And lastly, clearly, we need to make more use of proactive devices, proactive monitoring of patients, and more use of these telehealth and e-health services that we've been talking about. Thank you very much.
Wow. What did you think of that, ladies and gentlemen? Wow. It seems so complex, yet it seems so simple to comprehend. It takes in your paradoxes, it takes in what you'd said, and this is a perfect time and perfect place for Alexander Avshalomov to come into the discussion. And I should just say, ladies and gentlemen, we have not only a very distinguished mathematician, extremely well qualified, but over 30 years ago, he became a Grand Master of chess. There's no one at this table, or maybe even in this room, that can say they are a Grand Master of chess. This is someone who knows about the Botvinnik combination just as well as he knows about mathematical medicine. So, Alexander, welcome. It's a great privilege to have you with us. And I was particularly interested in the medical database that you created, the MRICM Smart Database, with 15 million parameters. But why don't we show your selection of slides, and let's hear what you have to add to this discussion.
Добрый вечер, дамы и господа.
Good afternoon, dear ladies and gentlemen. Good afternoon, dear participants of our session. I would like to join all our discussion and to tell you about our medical outpatient clinic and how it works, and the results, practical results, which we've got till now. And first of all, I would like to tell that the market for telemedicine is $30 billion in Europe, 500 million in Russia, 160 billion of rubles. Our proposal is in one desk, we integrated all main diagnostics which are used in outpatient clinic. Which kind of diagnostic? Clinical analysis of urine, blood, biochemical panel, popular tests like glucose, glycolized hemoglobin test on myocardial infarction, troponin tests. This is the test of the quantity of leukocytes which are very important in inflammation. ECG 12 channels, the measurement of temperature of AP, and just a great range of different devices. And you can see this telemedicine outpatient clinic, and all you need to do just to sit into this seat and to call the doctor, to push the button and call the doctor. Today we produce two types of this device, stationary type and mobile type, telemedicine model transformer, which you can use in any place. And I will tell a little bit in detail about that. The very important step was to create automized workplace for doctors, to force our doctors to work with telemedicine. Of course, it's a very difficult process because doctors are very conservative people. And to stimulate them, we created such workplace with 3 monitors. And these 3 monitors in one workplace. In one of them, a doctor can see a patient, on the other, the history case, and can monitor all the processes on outpatient model. Workplace of a doctor should be in video call center of a clinic. Thanks to Ralph for such great introduction, but I will add some information. I'm the head of the group of company of cybernetic medicine, in which we have a clinic of cybernetic medicine where doctors work, doctors of different specialties. We treat different chronic diseases, heart diseases, diabetes of the second type. And accordingly, in our clinic, which has been worked for 17 years, we have a great database and many diagnostic parameters. And I agree with Hyundai, and it's very important to analyze these parameters, and we need to structure them. And this is the main trend, how to get the necessary valuable information. In our clinic, we have video call center where specialists of different where doctors of different specialities are working: neurologists, dermatologists, cardiologists, and so on and so on. Please give us start the video, please. Just push. Just click on the video and it will work. In this case, continue, please. Next slide. So, unfortunately, presentation just was stuck. Here you see how a doctor works, and a nurse does 12-channel ECG, and after that she just sent all the data to doctors, and doctor consult the patient. Also, you can see blood tests. It can be. And we can do all kind of tests now, biochemical panel. And all this data are sent online to doctor, and the doctor can consult any patient. Also, we have optical cameras which can transfer the exact condition of the skin, for instance, and other visualization. Dr. Van den Kries said about the economics in healthcare, and from our point of view, the opportunity to have additional virtual outpatient clinic in different places will save money, and it is known. Let us continue with the presentation. Please give us the next slide, please.
Today we have the following examples. Cisco Systems company that makes health presence devices that helps make certain tests. This is a health spot, and as I know, it is promoted in the United States, but I haven't heard that it has been implemented elsewhere than in the United States. Another device made by a Korean manufacturer. It's a home device that can be used to transmit different information, including video information. And these are regular devices by some other manufacturer that helps transmit data digitally, electronically. So how do we see the application of telemedicine outpatient clinics? So if you look 10 to 20 years from now, you'll see that such outpatient clinics will be present both in towns and in rural areas, but also in schools, in military settlements, military bases, on airplanes. I'll show you this application in a minute. In airports, it only seems that this is too much futuristic. Today, our clinic has placed such outpatient clinics in big companies and also in one medical center in the Moscow region. So, and we provide online medical consultations today through those outpatient clinics. Here's our proposal on the outpatient clinic, the so-called transformer suitcase that is transformed into a workstation, into a desk, having all the necessary functionality, 16 different medical devices, and again the same principle of pushing one button click, and the video call center doctor will survey the data and respond to symptoms that the patient is telling about. What's important here, if you just provide video conferences, video consultations, and I saw yesterday Google announced a video chat system where you can press the button, provide your symptoms, and then somebody will consult you. But how can you consult on the basis of symptoms? This might be subjective symptoms. Therefore, without online tests, without the doctor having all the data in front of his eyes, and also all these devices that we use, these are professional medical devices authorized by the Minister of Healthcare. So without all this, a doctor cannot take a reliable conclusion. That's why we outfitted outpatient clinics with these important devices. And having that, the doctor can take the responsibility and take medical decisions. So what's important is that medical consultation is based on reliable information. Here is another example. You know, people on a plane often get some health problems. This might be due to some objective reasons, clogging blood, lack of oxygen, or some subjective things. People might be stressed, scared. So in August this year, more than 10 people died on board of planes. But this happens in different countries, on different airplanes and different airlines. So this transformer that you see on the slide helps provide medical treatment and psychological treatment, if necessary, to patients, to passengers who don't feel well. A few months ago in Europe, an authorization was given to use internet on airplanes, to make internet connection available on board of planes. Aeroflot has joined in, Transair, another Russian airline, and UTair, three Russian airlines has joined in, and they will offer internet access on board. And this will also make possible the use of these transformers and telematical devices. And this is a great way to help people on board of planes. My company is also head of the European Institute of communication standards where we create telemedicine standards together. We have suggested 24 standards that are now under discussion. As my colleagues mentioned, as Günther and Nick mentioned, accurate interpretation of medical data is the most relevant topic that will be on the table for many years to come. Mathematicians, IT experts, doctors, and because our workstation software helps digitize data, test data, and other information about the patient. One such module, one such workstation can create up to 1 million new parameters per year. Therefore, big data in medicine is the hottest topic of today. This slide demonstrates how much is already in operation. So here you see a factory that has its own medical center, and it has this medical module that basically helps workers of this factory get medical treatment, get immediate medical advice. In Moscow region, in the town of Troitsk, there is another module of that kind. There is another module of such outpatient clinic. So it is successful. And let me demonstrate one more benefit of our solution. So today, just to take laboratory tests, you have to come to the clinic and then 24 hours later get the results. At least 24 hours later, and only then you can get an appointment with a doctor. Telemedicine will help do all this immediately, instantaneously. Yeah, so you just come to this outpatient module, the test will be taken, results will be obtained, medical advice is provided. Thank you. That will be the end of my presentation.
This is just a further understanding of the speed with which it's moving. And Günther, I'd like to ask yourself and ask Kirill, the two things that have come up from Chris and Nick and Alexander is the fact that the slowest part of digitizing telemedicine seems to be the government and the reluctance of doctors to become much more technologically involved. So when we hear stories of some of the government legislation that is not allowing the speed of this, can you think of ways in which those two problems could be dealt with in some interesting way?
Yeah, I would like to give you an example that shows that the healthcare market and the healthcare domain is fundamentally different from other domains, and that innovation in the healthcare domain takes usually very much longer than in other domains. When you were asking this morning the question in which field we expect the most progress, I was not voting for life sciences and healthcare, because I know that from the idea of a new concept in healthcare to the implementation, you can count 15 to 20 years. It's really very long. And one example that shows that this is not a consumer type market, as you may remember, there was Google Health. That was supposed to be a web-based medical record to be merged with other sources of data to become one part of this big data stuff. But Google stopped doing that. Now they re-enter the scene via the consumer segment with Google, with a mobile Android-based platform. But for me, this clearly shows that we have a very highly regulated market, and also we do not have a global market, because physicians actually very much agree how to treat a certain disease. But when it comes to in which healthcare system they do that, it's all about specific regulations, the government, it's about specific reimbursement schemes, and you cannot simply transfer one market to the other, and that was why Google gave up and said it's too complicated to have 170 different markets. We stay with our big data stuff to provide you with the perfect advertisements, and if we do it wrong in the advertisement business, nobody gonna sue us, but if we do it wrong in the medical field, we have big problems, not just big data.
You had mentioned earlier the long cycle of development, but hearing all of these views and hearing about some of the issues, and of course the incredible progress that Alexander is making with the whole area of the cybernetic medicine. What are some of the observations you have about trying to move the Minister of Health to understand that this is as important as the most important innovation with petrochemicals?
I believe what we saw, I mean, what Alexander showed us, that's the end of the very long way they came to the final point. It took, how many years it took, Alexander, to organize this telemedicine clinic? Сколько лет это заняло?
Ну, мы начали работать в 2011.
We started in 2011, so it's a result of 3 years of efforts. 2 years we spent on obtaining the authorizations from the Minister of Health here.
Federal law. So basically, the initial, the federal law was initiated 2011, and for the moment it's at the nearby the finalization and nearby acceptance. But it took about 3 years to take the federal about telemedicine, electronic medicine. And I don't think, I mean, that's maybe it's not a fault of the Ministry of Health, but that's the problem of Ministry of Health. And that concerns the most of the biomedical project, because any step, the main law, I mean, from the time of Hippocrates, well, it's no harm for the patient. And the Ministry of Healthcare certainly make any actions in this perspective, in this paradigm. That's why, I mean, it takes so much time to check if everything is fine, clinical validations, and so on. But what's interesting, I think all those initiatives, we are talking about top-down initiatives, but I think the digitalization of the medicine.
Because patients that are recovering from orthopedic surgery will do better if they're more active. So they prescribe a level of activity to the patient, they give them a Fitbit, and now the doctor can monitor whether or not they're active. Mayo did their research on this and found that patients that used the Fitbit as prescribed recovered 20 to 30% faster than patients who didn't use their Fitbit. So what is happening is that we are creating new vital signs. So we used to think of vital signs being blood pressure, weight, heart rate, things like that. Well, activity is a new vital sign. And if you look at the two things that will have the biggest, or three things that will have the biggest impact on your health, regardless of whether or not you have a chronic disease or if you're completely healthy, are activity, diet, and sleep. All right? So what do these activity monitors try to help you with? Activity, diet, and sleep. If we can get people to do those three things better, it's more therapeutically beneficial than any drug that's ever been made.
Being a medical doctor, I would add to these three still treatment for the sick people. You cannot avoid this.
Right.
And again, the e-health and m-health really can help with this one, because the patient can monitor the receiving of the drugs in time, alarming, following the drugs, and seeing the progress. So the forces also work with the mobile health.
Yeah.
Nick, what do you say?
Yeah, I totally agree. And part of the work, for example, that I mentioned within the Manchester project in the UK, it is looking at registering more and more patients into these programs. So we're looking at going into pharmaceuticals, to supermarkets, and having kiosks to allow people to register. Now, again, some of that will still will still be attracted by fit people, but hopefully we're also saying, while you're picking up your drugs, would you like to register for this program? And we'll give you a device, we'll give you a wearable device or whatever, and you'll be part of that program, we'll help you monitor. The downside sometimes is, where is my data going to be? Who's going to have access to my data? Are you going to share my data with other people, which is a whole new subject, I guess, which is maybe for another day.
Who's going to have data of my bank account, of all of my bank? You have to reach a certain threshold before it becomes part of. Gunther, any thoughts you've had on this, interchange?
Yeah, what I would like to add is that there's another big issue. If we take the three of yours and then medication, we also know that 50% of chronically ill patients throw away their medication. And so this kind of context sensing can give us a good idea on why a therapy doesn't work. Is it because the genomic makeup of the patient isn't compatible with the drug, or is it that it just throws it away? So medication adherence is also a thing that we can tackle with this mobile computing devices.
I think what you find in the United States anyway, because I said this in Japan and the Japanese said, no, that's not true here because we're very obedient. But in the United States, half of all patients don't get their scripts filled. Half of those that get filled don't get followed. And so you only get about a quarter of the drugs that are going to the patient that need to go to the patient. And so how can we use these technologies to get better adherence to medical therapies? Because the other thing that people don't realize is that a third to half of all drugs don't work for the people they're prescribed for as well. And so how can we get better feedback to know whether or not that drug worked for you? And if it didn't, can we prescribe something different that will work for you?
Alexander.
Ну, я бы хотел сказать, что
I would like to say, you know that in 2018 in Russia, Russia will host the international championship on football, on soccer, and it's very important that such mobile devices can help us to measure our pulse, our arterial pressure, the number of paces, and in stadium we try to put our outpatient clinic to gather all measurements from all athletes in the process of training, and coacher can gather this data and monitor all of them and remind them about the necessary parameters. So integration, such type of integration of stationary telemedicine, outpatient clinics, and different mobile devices will be the future of telemedicine. Thank you very much. Конечно.
Spartak, so that Spartak maybe one day can win a championship. It's a big problem here in Moscow. Nick, the question of these paradoxes that Chris had so succinctly raised, and the question of the feedback loop of educating, of course, in the UK and the United Kingdom, where you have a national health service that are being encouraged to get patients to be healthy, as they always are, because there's a benefit. But at the same time, there's this pressure where hospitals don't necessarily want to do that. There seems to be no silver bullet. There seems to be, this is like a big bowl of spaghetti, and which piece of spaghetti you pull out, it might be random. But does it seem that we're moving in some international way forward? Is the World Health Organization involved in this? Does Hitachi have some ways in which they think some of these things can be accelerated?
Yes, and I think maybe the UK is not the best example, and I can say that as I live there, because they've done a lot of things wrong, and it is seen that, you mentioned earlier, that it's free healthcare, and it's always specified it's free at the point of health. It doesn't mean it's free, because we all pay for it as taxpayers. But if you look at a number of the countries, if you look at, for example, going back to the telehealth and mHealth, it's the Nordic countries that, in my experience, are leading the way, and that's partly because of geography and the weather, etc. And I'm sure it's the same within Russia as well. But they've been doing a lot of this type of stuff for many years now, and again, they are looking at having centralized expertise areas and regional regional centers for particular care. So they're saying, regardless of where the patient is, then this part of the country or this part of the region will centralize all that information and then treat, similar to how Alexander was saying, treating that patient wherever they are. Because we can't afford to send an ambulance to them, we can't get the patient to the hospital, so they're doing much more of that already. So I think all countries are heading that way. Funding clearly plays a massive role. I think the EU certainly, and the UK government, as I know, are pushing that. This is, it's going back to my earlier point, it's unsustainable how we run healthcare today. We can't keep doing it like this, so we have to look at different ways, and the only way we're going to do it is through technology. So I think that's what's pushing it.
Yes.
A couple of interesting things about Denmark. You mentioned the Nordic countries. Denmark implemented their electronic health record in 1977. Okay, that's 40 years before the United States implemented an electronic health record. So Denmark is 40 years ahead of the United States in digital health from that perspective. Okay, one other thing about Denmark, and you have to really credit the government for being very far-sighted here. Denmark is in the process of rebuilding their entire hospital system as a country. When they are done rebuilding their hospital system, they will have 20% fewer beds than they have today. When people look at the demographics of Denmark, aging population, more old people, they would say, no, you need 20% more beds when you're done, not 20% fewer beds. Denmark said, we want to create a constraint in our country of hospital beds so that it forces more care to be delivered in the home. So again, if you look at Denmark, they've been ahead of every other country in the world in digital health information, and they've been ahead from a policy perspective to force the healthcare system, the doctors and the hospital system, to adopt digital health because they're taking away the alternative, which is to put more people in beds.
So Chris, would you say that what is really needed in the future is innovation education for the profession, for the medical profession? Because how are we going to bring in people that are trained and taught that go beyond the conventional medical school and medical training?
Yeah. So I have a model I call the innovation cycle. And the innovation cycle says that you only get innovation if you have the following conditions. There has to be a failure that creates pain, that drives tension in the system. You innovate then to eliminate the tension, and then that delivers growth. The problem with most healthcare systems is no one wants to create pain and tension in the system. So when I'm in Finland and I talk about their healthcare system adopting these sorts of things, they say, well, why should we do that? We're paid by the government, they give us more money every year. No one's going to be elected on a platform of lower healthcare spending. Therefore, we're completely insulated from any change in the system. You can't find doctors around the world that want to embrace tension as a way of driving innovation. And it's not just doctors, it's people in general, which is the brilliance of what Denmark is doing. Denmark is saying, I'm going to create tension in the system to force doctors to deliver care differently. Because I realize if I don't create tension in the system, we will never change healthcare delivery. And so the United States right now with Obamacare is creating tension in the system. They're saying, we're not going to pay you the way we used to pay you. You have to adopt technology. At first, we're going to pay you rewards for adopting technology. After 5 years, we're going to assess penalties, tension and pain for not adopting technology. So that's the only thing that human beings respond to is failure, pain, and tension. That's how all innovation works in every country in the world, and that's what you have to be willing to do if you're going to change your healthcare system.
Winter, what do you think of that? No gain.
Yeah, that's probably right. I agree with a lot of your paradoxes. And it's also that technology can solve some of the issues that you're mentioning. For example, the inverse innovation pyramid, that the ones that are the aged persons are the ones that are least interested in using technology. So what we did with this keep in touch kind of thing, we tried to overcome these barriers with technology. To some extent, this is possible. But of course, there's a second pillar in the whole system, which is the healthcare processes. And we not only need innovation in the technology, we need actually healthcare process innovation. That probably is the place where disruptive creativity is most needed, because if we don't change the way medicine is practiced, we will have a hard time to really get the benefits out of all those systems.
So let's look at healthcare process innovation by analogy to the computer and typing innovation. So when computers were first developed, people used them just like they did a typewriter. There was no process innovation. They would type on it, they would put the paper in, they would have a secretary do it. It took about 10 years from the introduction of a new technology to get process innovation. And then what happened with the process innovation is we didn't need secretaries anymore. We typed all of our own memos, all of our own emails, because memos went away. They were replaced by emails. So what you find is that there's generally about a 10-year gap between the introduction of a technology and then the application of that technology to change process. And so I don't think healthcare will be any different. In fact, it'll probably be slower. That might take 20 years to change process by implementing technology. But technology is the only thing that changes process. It just does it with a lag. And that's started from the dawn of man, that technology has changed process. And right now we're at a point where in most countries, the United States, most of Europe, the average age of a doctor is about 55 years old, which means that those doctors are saying, I don't want to change any process for 10 years because then I retire. I'll let somebody else change process when they graduate from medical school. So we have about half of all the doctors that I do not think will change their processes for the next 10 years. So that's why I say it's more of a 20-year type of process.
Oh my God! What are we going to do? Alexander, let's get some chess moves.
Я хотел бы как раз.
I would like to prove the words of Chris, because in our clinic there are doctors of various ages, and 35 age doctors and younger. They like to work in telemedicine. They are very interested. And even some of them, they just told that they prefer to work in telemedicine. And who is above 35 years, 50 and above, they are afraid to anything new. And only after pressing on them, they start to work in this direction. So I agree with you that the age is very important in this.
Well, what I can say of this session, because it's come time for us to end, is Atlichna. It is great that we've heard this from such great knowledge, such great experience, such great expertise. Please join me in giving a big round of applause to Alexander Avshalomov. Alexander. To Kirill Kayem from Skolkovo. To Nick from Guildford in Surrey in England. Yes, England. Chris has come all the way from Utah. Chris, we love your paradoxes. It's no paradox for us. This is the definite way of forward. And Gunther from Austria, thank you so much for all of your input. It was fascinating. I hope you all enjoyed this. And now, ladies and gentlemen, the doctors are not needed because it's time for this. So thank you very much. Thank you for coming. And thank you, Open Innovations.